For young investigators, it's very important to start early.
Following what your specific passions are is worthwhile.
Try to stay focused. It's hard sometimes to say no to some things.
Choose your fellowship wisely. Make sure you're going to a fellowship where there's opportunity to publish.
Generally follow major updates from the large cardiology journals.
Don't discourage yourself. It's a hard road, but it's a lot of fun, so I would encourage you.
All right, in this next session, we will move to case demonstration. So we discussed electrosurgery, but what about now specific demonstrations? How does it look, and what are the steps that we need to follow? And we are so privileged and honored to have Dr. Adam Greenbaum on faculty of TIO 2026, and he will start with a case on SESAME septum modification. Adam, over to you.
Okay, what I did was record a case of SESAME from a few weeks ago. I'm going to let this video run and walk you through it. I have it on silent and I will talk through it. I don't know if you want to stop and ask questions. Anybody on the panel, certainly feel free. We can do it that way. But the reason I wanted to re-record a case more recently is because the technique has changed since we originally showed this case live back in, I can't remember when it was, 2021. And people still go to that video and try and do the procedure some on their own. And I thought I would show you the way we do it now because we have iterated the procedure. So this patient, just in brief, is an elderly woman who had a prior TAVR, who also had MAC-related mitral disease, and two things had happened. The TAVR valve had degenerated, but also the MAC had progressed to more significant stenosis and regurgitation. And so, as typical with these patients, they do not have enough room. She's not a good candidate for a SAPIEN 3. We'll need a dedicated valve. These are fully covered valves, and so we'll eventually need maybe a fully covered dedicated transcatheter mitral valve, and therefore we'll need septal modification to improve the neo-OVFT. So this is not being done for hypertrophic cardiomyopathy. And of course, the technique is the same, but maybe the amount of muscle that you cut is a little different. So here you can see some of the baseline imaging showing the mitral valve. And here you could see the degeneration and some of the leaflet restricted motion of the TAVR valve. So the plan for this procedure is SESAME and TAV at the same session.
Okay.
We will often do, if the aortic valve needs to be fixed for the first time or redone, we will often do this procedure in a combined setting. Whether you do one first versus the other, we can get into in the discussion. But in this case, since there's already a TAV in place, we chose to do the SESAME first. We do not use cerebral protection for these cases. There really hasn't been any strokes. Here you can see some of the baseline hemodynamics. This is us pushing the catheter farther down to the apex to check for some dynamic gradients. So there was probably 40 millimeter gradient across the valve and an additional 10 or 20 down at the apex. So access for SESAME, if you're only doing SESAME, it is 2 arteries. One for the septal guide, one for the LV guide. If you are going to do it combined with TAVI, then your access is the same access you would use for TAVI. So whatever your best artery is for the TAVI sheath, and then the other one for the limb, that will be the LV guide. Now, the only word of caution here is we use a deflectable sheath to help get the septal catheter, the septal guide, aligned as best possible. And since the standard Agilis that we use is only a 71 centimeter working length, it will fit around the arch and get to where it needs to be. And most people, if they're not particularly tall or they don't have a very tortuous aorta, but you need every bit of that length. So we won't put the TAVI sheath in first. We will be sheathless with the Agilis. So in the better leg, the leg that ultimately will deliver your TAVI or whatever your better leg is in terms of arterial access, there is an Agilis medium curl. And inside that is a 7 French, and this is a Medtronic Champ guide. It's not commonly stocked in most labs for coronaries. It's kind of like a multi-purpose. It comes in a 1, a 1.5, and a 2. I think outside the US, you may be able to, maybe even able to get wider a range of that catheter. We typically start with a 1.5, the middle one, and then we adjust as necessary. So we've crossed the valve. There's an Agilis that is around the arch into the ascending aorta. There's a Champ guide, and inside that is the standard traversal equipment. But in this case, it's a 40-gram Estato wire, and it's inside an 014 microcatheter. In this case, it is a Corsair Pro XS. And that's because so whatever your high-tech 014 catheters that you might use for CTOs, and it's just better so that you can help twist through the muscle. We line up the catheter fluoroscopically based on 2 views that have been determined by the CT, and then we confirm our location by TEE. What you can see in this picture is that we're basal enough, but we're too shallow. It looks like we would just shave off too little of the hump. So we will swap out to a larger catheter if that's the case. If we find that we are just too big, we will downside the catheter. So I think we went from a 1.5 to a 2 here, and then we will reassess. Again, we did not go through CT planning. We're just talking about doing the procedure, but the 2 views, there's a front and a side view, again, common to all of these procedures. The side view is often a compromised view, because to get to a true side view, it would be very RAO and very caudal. The camera won't reach there. So I typically go to what the max my room will allow, and it's about 30-30 RAO caudal. The front view, which in this case is
Adam,
right screen. Yes.
Adam, can you briefly pause? So you use this Medtronic Champ catheter, but I can imagine that most of the operators that are now following have no access to this catheter. What would be your, let's say, more common catheter shape that could be used for this purpose? Is it an IM catheter? Is it a Lima catheter? Or is it an Amplatz type? What would be an alternative shape?
Yeah, I would use a multi-purpose 1 or 2 would be my second choice. if you can get Medtronic catheters, I think you'll be able to get them. I don't see any reason why you couldn't. They are a nice guide for coronaries, by the way. You could use a multi-purpose 1 and 2. You can use an AR, but an AR guide tends to point you a little shallow, so I haven't had a ton of success for that. You can use a JR. So I think those would be the sequence of guiding catheters I would use if you did not want to use the CHAM. And again, if you are too shallow, I'm sorry, I misspoke earlier. If you are too shallow, you need to, meaning the catheter is too big, right? So it's open up too much, you would downsize to a smaller one. If it's too hard, if it's too deep, meaning it's cutting across, you would open it up. You could either open it up by adding the back end of a wire, or you could switch to the bigger one. So that would be the guide choices. So what we're doing here now is that you can see in the image, the Agilis catheter is bent to pull the catheter over to the right sinus, the right coronary sinus, because the septum where we really want to enter is at the nadir of the right coronary sinus, or slightly to the left-right commissure. So by what you can see here with the change in the catheter, we now have a better trajectory. We're not, the first catheter was too big, so it was going to shave just a little bit. And now we are a little bit, by going down a size, in this case, we went from a 1.5 to a 1. We now are in a better location with a better trajectory. We spend all of our time here because the more time you spend with the trajectory and the position, the easier the rest of the procedure is going to be. So we're basal in this X-plane of the esophageal view. And if you look at the short axis, we want to be somewhere from the nadir of the right sinus, sheeting a little bit towards the left-right commissure, because that will avoid the conduction system. So what you can see there is Dr. Gleasing is pointing out that we're probably right at the base or the nadir of the right sinus. Once you're comfortable with your location, we do enter this muscle with energy, 40 to 50 watts, and we just push in. I like to put a little 014 torpor on it. We don't typically do that with leaflet traversal, but in this case, I do like to twist a little as I go in. You will see a few PVCs to know that you've entered the muscle. Once we do that, we can spin the microcatheter in for a little bit of support. This is a 40-gram tip Stato that has no tip on the end of it. It's a straight tip. And if we had a good location, a good entry, and a good trajectory, I just push the Stato 40-gram tip wire without a tip straight through and back into the LV. Then what we do is we take a look at the depth and the length of our traversal. And that is done with X-plane. We usually use this sepia color. We seem to be able to identify the wire a little bit more easily. And we will go into the stomach and do NPR. Now, in this case, we had determined that we were shallow and we were a little medial. So the easiest way to correct that, rather than remove everything and start over, is to use the first wire as an anchor and now add in a second wire in what I refer to as a parallel wire technique. So the Stato 40 was changed out to a 20 for safety. The microcatheter was backed off. And next to that wire, we brought it back in, the microcatheter with the new Stato 40. You can usually get into the same hole without energy. And now by manipulating the guide, clocking and countering, or using your Agilis, what we've done here, we were shallow. So in the ARIA view, our second wire is above it. And in the front view, since we were medial, the second wire is to the right of it or lateral. And so what we're going to do here is just take another wire and push this wire straight through in a better trajectory. So now you can see.
How important is the biplane here?
and in the front view, a little bit more lateral. Question?
Yeah, so how important is biplane view here? Because I see you're operating in biplane.
Yes. So we find biplane helpful, but I think with this new technique, by taking a straight 40 and lining it up trajectory-wise at the beginning, I think you can now accomplish this procedure with a single plane lab. You would have to go back and forth. I would make sure going back and forth, you're in your correct orientation. I would probably enter in my REO view, and I would drive the wire through in the REO view. I would then go to the LEO view to see that I hadn't deflected medial or lateral and make my adjustments by going back and forth. It has been done with this technique in single plane labs.
Yeah.
So to confirm that we are at the appropriate depth and that we've traversed long enough, we will now go into the stomach with an MPR. You will see that in the upper left and bottom left boxes. Dr. Gleason is finding the wire in those two views, and then that will create a dot in the upper right image, which is a cross-section of our wire. So what you can see in the upper right images is the dot. Now it looks to the crosshairs on the upper right image are right on our wire. And what you can see is we're about 40% deep. We aim for about 50, maybe 55, 60. In this case, we didn't need to make a ton of room. We thought we were about 40% depth. We thought it was going to be okay. And so we wind up taking this depth. But you can see this is spend a lot of time here. Let your imager line up the MPR on the wire as best they can. And then he will pan from base to apex and back so we can look at the depth during the whole traversal. In this case, we were looking for about 7 millimeters, and that's what we were. And we decided to take it. So now once you've done that, it's time to snare. This is just a 3-loop. This is an 18 by 30 snare. What we do in this case is we open the snare in the LVOT and then we drive it down to the apex so that we don't get around the pap muscles on any cords. And then we swap out the 40 for a 20-gram tip just for safety. We put a little bend on it and we're able to get into the snare and snare it. We then, again, we do not exteriorize at this point. We just lock it down, and then we actually pull the system. What you saw there was we pulled the system up a little bit, and now your imager will look to make sure we did not wrap around any cords and that we're in the center and we're right across from A2. So that's what Dr. Gleason is doing now. You can clearly see that we are between the papillary muscle heads and we are not trapped behind them. So that's important because I've heard of a few cases where they actually perform SESAME and cut a cord and created severe MR. In this case, we wanted to balloon assist a little because we were a little shallow. And if you had a really tough time getting through muscle and you think it's really thick and you want to splay a little bit more, you can take a small balloon, in this case, a 2-millimeter balloon, and balloon the muscle, which is what we just did here. And now we will add in the telescopic system to deliver the flying V. So here's where practicing the flying V during your leaflet modification will help you so that you can perform SESAME. So now we've taken out the balloon, we've added the telescopic system, an 014 microcatheter, an 035 microcatheter, in this case, a Navicross. By the way, this is a 150 014 microcatheter, a 130 035 Navicross. We're only using the inner microcatheter to help deliver it through the muscle. We need this telescoping system. So once the flying V has been created, now it's the same push-pull that we discussed during the last session to deliver the flying V. Again, the introducer to the snare has been added. I'm pulling on the end of the wire. Bacillus in this case is adding it, and we've delivered the flying V through the muscle into the LV. Now we will remove the
Adam, how?
the 014 microcatheter now gets removed. Go ahead.
So why is the Navicross important in this case then?
Because in this case, we are going to flush both limbs. And remember, your guide is sitting on the septum. So flushing the guide does you no good. So we're actually going to flush the Navicross. So there's a little gap. By using an 035 Navicross on 014 wire, we'll be able to deliver saline into the muscle. So we used the telescoping 014, 035 to get it through the muscle. And now we have just removed the 014 microcatheter, just leaving the Navicross in front of the flying V. On the back end, we're going to cut, just like we did, just like I showed you in the last session. The other difference is that we're also going to insulate the left ventricular guide wire as well. So we're hooking up the bovie to the back end. You can see there's a TUI on the back end of the Navicross. There's two locks. There's two 014s to lock it. There is a bovie. But what we've done now is we've taken a fine cross and we've cut the fine cross to 48 inches exactly. We've cut the lock on the back end of it, so you can see there is nothing on the back end of that fine cross. It's going over this short wire. By cutting it to 48 inches, it will be long enough to be outside the guide, but it will be short enough that the 014 wire will be exposed. So what you can see now is the JR4 guide that is in the ventricle, that's across the valve. We've just inserted the fine cross. We're now inching up the LV guide that will eventually cover that, leaving just the flying V exposed, and we will lock that relationship down. Here's why that 48 inches of fine cross is important. We can get an 035 torquer over that because we've cut the back end off. Now there's an 014 torquer that will abut and lock the relationship between the microcatheter and the wire. So what we've done here is try and fix the relationship. So you can see the flying V is just outside the Navicross. The fine cross on the LV limb is just outside the flying V, the guide, and everything is being locked. So now we have two syringes. We have a small 20 cc syringe to flush the Navicross. We have a bigger syringe to flush through the LV guide. We will flush both limbs. We will energize and we will pull through the muscle. We typically would set the bovie here at 50 watts. It's a little bit less than I do in leaflet modification. Not sure what the exact amount is. I think Dr. Khan uses 70 still. We will infuse, we will pull, and we will energize. There are a couple of things we do to try and prevent steam pops or undesired injury. We flush both limbs. We actually lower the blood pressure. This is not the time for someone's blood pressure to be 200. We like to pulse the energy. We will pull, pull, pull as we continue to flush to cool down the muscle. And we make sure that our catheters are well aligned. If you look at the right image, you can counter or clock the guide so that they are superimposed in your front view. The catheters should look side by side in your REO view. As you pull, if the muscle is tough, the agilis and the champ guide will drive forward. So somebody usually holds them back. So the person in position 1 will hold the agilis and the champ guide to prevent them from diving forward. The person in position 2 will grab both guides and pull. Someone will be flushing, usually person 3 will be flushing both, and then you actually have a 4th person press the yellow button. So here we are clocking the guide that's in the RV. Clocking will bring you medial. And here is our pulsed energy. We're flushing, we're pulsing, we're pulling in a stepwise fashion. If it's coming easily, of course, you can continue to in one swoop. But if you find that the muscle is particularly hard, you can do it in this stepwise approach. Once the cut is created, you disassemble your system. If you were doing it for Holcomb, you could go back in and check gradients. But the most important thing here is to now look at the cut and to assess for any complications. So that again is done by TE imaging. And what you could see Dr. Gleason doing here is he's pointing out the cut. Again, somewhat shallow in this case, somewhat intentional. You will often see over the first 5 minutes that with continued contraction, the actual cut will splay right in front of your eyes. It should not go much deeper, but it should start to splay. In this case, we go on, of course, to recheck hemodynamics and then go ahead and fix the TAVI, which everybody here knows how to do. So I can continue to let this play if you'd like to see the end of it, but I think now will be a great time to ask any questions and then discuss any of the finer points. Here you can see an esophageal
Giuseppe, any comments?
view, a longitudinal view, long axis of the cut.
It is actually an amazing procedure. It's kind of moving from transcatheter mindset to surgical mindset. It means that we need to be patient because it takes time. And actually, we have to accept that. Because when we face this electrosurgery procedure, we need to keep in mind that it's not like half an hour to put a valve in the aortic location, that's it. So I don't think it's so easy. And actually the question for Greenbaum is, in this case, you had a gradient of 40 and 10 at the level of intraventricular gradients. So in this case, you perform first the SESAME because the risk was to have a suicide heart with the positioning of, let's say, valve in valve, what was, the clinical consideration to start with the SESAME here.
We haven't had much difficulty performing a SESAME through a stenotic valve, meaning the hemodynamics seemed to do pretty well. In this case, since we were planning an evolute, I thought it would just be easier to negotiate, through the first TAVI before going on. One could argue to do the valve on valve first, because if you got a little bit lower by accident with the second valve, it would cover part of the cut. The only thing you really could do is cut below your TAVI. In this case, we knew we were going to try and go higher with the second valve, so it wasn't much of an issue. So that is sort of how the case ended, and I'm going to stop here and we can continue the discussion. The only reason to keep this video up would be if anybody wanted to go back to any specific point of it. I'll leave that up to you, Nicolas.
No, let's continue with the discussion again. Also, people in the audience are quite impressed. But Mohamed, you go first.
Yeah. Okay. So just one question regarding the strategy again, which is like what you do first, valve first, or SESAME first if you're going to do the aortic valve as well. So doing it vice versa, as I understood from you, is also possible, like doing the SESAME first, doing the valve first, and then you can safely do the SESAME through the aortic valve without injuring it. So this is one question, and the other one would be a bit technical regarding the navicross flush. If you can explain this again, why you're flushing through the navicross and how to do this.
Sure. If I am doing a combined TAVR SESAME for AS and, for that matter, risk of suicide ventricle or combined HOCM, I actually tend to do the TAVI first. I just get the valve out of the way. I try and get my valve placed high, and then I go on to the SESAME. The reason I like that is that actually the TAVI valve now fluoroscopically defines the LVOT. Great, right? So I know that if I go to my front view and I am right in the middle of the stent frame of the TAVI valve, it tells me that I'm right where I want to be. Because for a hokum or suicide ventricle, whatever you want to call it, the goal here would be to be right in the middle of the LVOT. So I tend to do the TAVI first in that situation, and we don't tend to have any issues with hemodynamic compromise by holding up the leaflets with the catheters going through them. I guess you are correct that if you accidentally were concerned that you were going to injure a leaflet, then of course you knew you were going to replace it, you could do the SESAME first and then place the valve. If you keep the septal guide under the aortic valve and up against the wall at all times, then in actuality, you should never injure anything. And I didn't mention it during the video, but while you do the push-pull, just be cognizant of the fact that the guide is underneath up against the septum so that your wire on the push-pull doesn't accidentally slice the aortic valve. So if you're careful, you should not have any injury. But if you want to do it the other way first, you certainly can. Your second question about the navicross is there have been a few cases with a bad outcome that we think was related to a steam pop that may have occurred in the muscle. Because again, unlike what you described in your first talk where we're in the bloodstream, actually our energy is being delivered in muscle here, and it's tight quarters. So we think we should do everything we can to prevent heat buildup and potentially a steam pop. And so what we are doing is flushing the myocardium. So you've created this tiny little channel with the 2O balloon. You have a navicross, an 035 navicross on an 014 wire, so there's a gap. So by hooking up a small syringe, you can flush and you're actually cooling the myocardium. We actually have moved to iced saline. The ice cold, a saline that you use to prepare an evolute, to shrink the nitinol. We use that same saline that's in the refrigerator, and we actually use cool saline to cool the intramyocardial limb and the LV limb. Both limbs are insulated, and we lower the blood pressure. What we don't want to do is make a cut and expose the mid-myocardium that is not used to seeing that pressure, to 200. So we'll tell the anesthesiologist to let the pressure drift down. We're trying to do all these things to prevent unwanted myocardial injury.
Philipp, a last question from you.
Adam, a fantastic demonstration. How do you judge success immediately after the procedure? How do you know that that's sufficient what you've done?
So we don't really know if in terms of pre-TMVR, if we're doing it for hokum, we'll often see, we used to see greater than 50% reductions in resting and provocable LVOT gradients. With a little bit more conservative approaches, better control of the energy, we're probably seeing about 40% reductions in both. If I see that, I know that's going to spread over the next 30 days, and by their echocardiogram at 30 days, that they're going to have success. The ultimate determination of whether we made enough room in the LVOT for a mitral valve, that depends on one, how much room you needed to make, excuse me, to begin with, and two, how much time goes on. So we usually repeat a CT about 4 to 6 weeks later and then remake our measurements. Again, some of these patients didn't have gradients to start, so there wouldn't be any hemodynamic assessment that would tell us that we actually did anything for them. But you could also see how it spreads over the first 5 minutes. We can assess the depth, we can assess the width, and we can get a sense based on our experience of what it's going to look like at 30 days. The whole ventricle will grow by 30 days, and that cut will splay. And so that's pretty typical. Usually what you get by 6 weeks or so is your final result.
Adam, we have so many questions from the audience. Maybe a first one. What about cerebral embolic protection? Is that routinely necessary when you do a SESAME?
It doesn't seem to be. We've done about 150 cases. We had one woman with a little ocular event that probably, and a horrendous arch that probably related to the agilis scraping the arch coming around, which is what, we're very careful when we flex it down. But you're vaporizing tissue, you're vaporizing muscle. There is no calcium. There's nothing like these degenerated leaflets, and we just don't see any strokes, so we don't use it. and we haven't had any strokes for it.
Yeah. And what about conduction disorders and need for pacemakers after SESAME?
So because we confine our cut to somewhere between the nadir of the right and the left-right commissure, we are avoiding the conduction system. We will sometimes see a left bundle branch block after the procedure, very similar to after surgical myectomy. Those are the confines of a surgical myectomy. So if a patient had a right bundle branch block to start, we might cause complete arc block by creating a left. Again, similar to surgical myectomy, the incidence of needing a pacemaker after SESAME is about 4 to 5%, again, similar to surgical risk. Whereas alcohol subablation, as you know, often causes a right bundle branch block, so it's different.
Yeah, yeah. Well, thank you very much, Adam, but you stay with us. I would also like to thank our panelists here, Giuseppe, Philipp, and Mohamed, for an exciting session, 2 sessions on electrosurgery. I will now proceed with the next session, where we will have more case demonstrations on Lampoon and Basilica by Adam, and we will welcome our new panelists. So thank you very much, and stay tuned for the next session on Basilica and Lampoon.